एक बार ही सुनो, आप बाहर जाके बोलो लोगों को अंदर आने के लिए। ये लेके जाओ।
Hello everybody, please settle in. We're starting our session. Good morning everyone and welcome to our second session today on empowering beneficiaries and strengthening monitoring mechanisms. Today's session examines the effectiveness of these two important elements of the PMG implementation and examines how they can be further enriched. In this session, we examine if there are practices, tools, and technologies worth adopting from other organizations and industries that would empower beneficiaries and deliver better results for monitoring. Without further ado, it is my pleasure to welcome the panel today, led by our chairperson, Mr. Manoj Aggarwal, a seasoned IAS officer, batch of 1990. He has an illustrious career and has extensively worked in the government of Gujarat. He currently serves as Additional Chief Secretary, Department of Health and Family Welfare, Gujarat. I would now like to extend a warm welcome to the co-chair of the session, Mr. Abhishek Singh, an IAS officer from the 1995 batch and a seasoned civil servant. He is currently President and CEO, National E-Governance Division, and MD and CEO of Digital India Corporation. We welcome you, sir. I would like to now welcome the moderator for today's panel discussion, Ms. Malti Jaswal. She has over 3 decades of experience in general and health insurance practices in leadership positions. She has been closely working with the PMJ scheme and serves as advisor at NHA and senior consultant World Bank. I would now like to welcome the panel. Our first panelist for today is Dr. Praveen Gedam, an IAS officer from the 2002 batch. He has led many initiatives in PMJ and has been part of the core building blocks of the Ayushman Bharat digital mission in his role as former additional CEO, NHA. Our next panelist for today is Mr. Manashvi Kumar, an IAS officer from the 2004 batch. In his career in the public services, he has held several pivotal roles in the government sector and currently serves as Joint Secretary, Ministry of Health and Family Welfare. Our next panelist for today is Mr. Rajat, a partner at Deloitte India, specializing in government and public services with over 20 years of illustrious experience. Last but not the least, I would like to welcome Mr. Arunchalam, a seasoned professional with over 17 years of corporate experience. He currently serves as consulting president at the Institute of Actuaries of India. I would now like to hand over the stage to our moderator to commence today's session.
Thank you, Noenika, and welcome to all the senior dignitaries, to this session, and welcome to all the participants. I hope the next 1 hour, now our time has been cut shortened and you can have your lunch still on time, even though we don't start on time, but you will have lunch on time. That's my promise to you, provided you cooperate, right? Okay, so we will start the session now. I would like to give a brief presentation just to set the context. When we say beneficiary, can we have the presentation? And how do I run? Right click? Okay. So just this context setting presentation, when we say beneficiary empowerment and strengthening monitoring mechanism, just to put the context, I'd like to briefly go through, So in PMJ, how are we empowering the beneficiary? First of all, we have general IEC, wall paintings and mechanisms of pamphlets or ASHA workers. And then we also have, that is a general IEC. But then when we say empowering the beneficiary, we mean a specific targeted message to each beneficiary, not a general publicity and advertising. So it is informing the beneficiary about his or her entitlement at each step. That is what empowering the beneficiaries, because our beneficiaries are unaware, they are uneducated, they don't know what the entitlement under the scheme is about. And then also redressing their grievances, not only guiding them, but also to tell them how they can redress their grievances, and also collecting the feedback through the voice of beneficiary. So what is their experience under the scheme? How are they, relating to the scheme? So we do it under various, SMS, call center, app, grievance portal, IEC, social media, card, at the back of the card, all the information is also given, feedback letters. These are some of the mechanisms through which we empower the beneficiary. I'm trying to run through a little fast so that, we can make up for the time. So when I said beneficiary empowerment, that at each step, when the card is made, we tell him that your card has been made and this card entitles you to 5 lakh of cover. In case of any difficulty, 14555 is the call center. When he comes to the hospital for registration, we send another message. When the package is booked, we send another message that this package is booked for this much amount in this much hospital. Are you aware of it? You should not. At that time, we also inform, do not pay any money. And if anyone asks you for money, call here. So that at every step the beneficiary is informed. At the time of his discharge also we inform that you are entitled to free medicines. If you do not receive free medicines, call us. And then we also collect the post-feedback discharge also, post-discharge feedback also. I'll come to that. So we have a call center. When I say NHA, we means NHA plus SHAs together. So there is a national call center, states have their own call center also. We have received more than 1 crore, nearly 1 crore calls in the call center from the beginning of the scheme, and most of the queries are, am I entitled? Most of the people are wanting to get covered under the scheme. And where is my Ayushman card? How can I get my Ayushman card? Then others are relating to hospital, about, where can I get treatment? Or I was denied treatment. Sometimes they call for denial of treatment or sometimes for collection of money. And those are the grievances that we receive on the call center. We also make outbound calls to the beneficiary. At very crucial junctures, we make the calls. One call is made to the beneficiary at the time of after discharge, within 3 days of discharge, whether you received the treatment, whether everything is all right, did you pay any money, or any other problem you had, any feedback you have about the scheme. Then after 15 days, we make another call to check the health status. How is his health? Is he feeling better? Is the treatment was all right? So this is a summary of the feedback that we have received. Around 90% people are very happy about the scheme. Their experience is good to very good. And around 86% people have said that their health is better. There are cases where death is also reported. Not that everyone is feeling better, because those are serious cases who could not be helped. And then there are people who say no improvement, or people say they did not have good quality care. So those cases are referred to then the concerned state, for them to take further action on. About the grievance, we have a very easy grievance mechanism for the beneficiaries. They could call, they could report in on the social media, on the portal, or walk in, or a letter. Any way the beneficiary would like to reach us, we have tried to make it possible for the beneficiary to reach us. And what we take very seriously are 2 categories of grievances. One is an SOS, what we call as an SOS, where the beneficiary is in the hospital and being denied treatment. That we call as SOS, and it is to be handled within 6 hours. There is an escalation right up to the SHA CEO. And then there are other about the poor hospital experience, about out-of-pocket expense or benefits not treatment denied. These grievances are the most serious grievances that I mentioned. There are minor other grievances which are routine, but money charged is one thing which we take very seriously. And if there is any expense where the beneficiary has collected receipt and there is then we ensure that the beneficiary is refunded back that money through the state health authorities. Now coming to the monitoring mechanism, the second part of the the session that we have, there are three main key areas through where we monitor the the scheme. One is an insight portal. Most of the people from states are aware. Those are the portals of the scheme where performance on different parameters is given on the cards, on the claims, on the then there is a state's overview reports and MIA monthly and yearly reports of state scorecard, fact sheet, states at a glance. Then the impact portal is about the operational efficiency of claims. How quickly the pre-authorization is approved, how quickly the claim is processed, how quickly the payment is made. These are some of the 3 key portals. Coming to a very important part of monitoring, which is the key part of monitoring of this scheme, is about PMJ anti-fraud framework. Right from day one, we have tried to, any fraud framework is built over 3 pillars: prevention, detection, and deterrence. So we have ensured that in the scheme that we have taken adequate measures in all the 3 aspects. How do you prevent? By we have guidelines, we have, all packages, we have reserve packages, we have, systems and mechanisms in the IT system checks are there. then detection becomes, even if we put the best of the IT system, I'm sure the fraud happens. It cannot be escaped. So then our job is to detect that fraud. And we have, analytic tools for fraud analytics that we carry out. We carry out medical audits, we carry out investigation. We also have a whistleblower and an anti-fraud helpline. Our helpline 14999 also has a voice, for reporting fraud confidentially. So that if there is somebody who wants to report, but then they does not know how to go about it, they can do that. Then deterrence is about the punitive action that will follow after a fraud is detected or after a fraud is confirmed. So all of these areas have been taken care by NHA along with the help of SHAs. There are two institutions that we have. One is a NAFU and one is SAFU, National Anti-Fraud Unit, and whose role is to have lay down the guidelines and the stewardship role, and State Anti-Fraud unit is to implement and also to steward at the state level. And we have under the fraud control, we have a lot of things like we have a portal dashboard called Radar, which is just like Radar. Its job is to locate what's happening where, to give the trends, to know the utilization right from the district or block level, hospital level, package level, right up to the state level and the national level. So it's a very useful tool for the state health authorities, SAFU units. Then if a fraud is suspected, then that transaction or entity is shifted onto another portal called FACTS. That is the very sophisticated portal. Both of these are very sophisticated portal, and at the back are lot of AI/ML driven triggers which are run, or algorithms which run to point out which are the suspicion cases where you should focus, because it's a scheme, such a mega scheme, you can't be controlling and you can't be looking at everything. So what you should look, how do you find the needle in the haystack? So these are the tools for us. We also have medical audit, we have capacity building of the states, audit of audit. These are some of the mechanisms that we have. And how does our anti-fraud framework, compare with what happens in rest of the world? So this is a very crowded sheet, but this is available on our website. This presentation will be available, but that is just to indicate that what we have adopted in India for PMJ is some of the best practices, in many of the countries of the world. Like the comparison here is Indonesia, Korea, Philippines, Croatia, Turkey, USA. This is a study done by the World Bank for, what are the prevention, detection and deterrence mechanism deployed for large healthcare schemes, where the large health insurance schemes, and we have adopted most of these, and we have improvised on many of these. Like for example, biometrics are done only in one another country, whereas we are insisting on 100% biometrics here. But then I think one area where we may not be comparing to some of these countries is maybe post confirmation of fraud action, the legal action or the punitive action that needs to follow after the fraud. That may be a little weak area compared to the other countries of the world. But this was a short presentation just to give you a feedback. I would like to end my presentation with all of you to hear voice of our beneficiary. Can we play that? It's just for 1 minute.
काफिया के नाम से है सर। तो यहाँ पे जो हमारा इलाज हो रहा है तकरोही में, तो सर हमको बहुत अच्छा है, और यहाँ पे इतना फायदा हो गया है सर कि हम तुम समझ लीजिएगा कि हमारे जो मतलब ऐसा लगता था कि जैसे चक्कर आता था, जैसे गिर जाएंगे, काम नहीं कर पाते थे, शरीर में मतलब बुखार,
थोड़ा आवाज ऊंचा कर दीजिए,
बुखार आता था। और सर कमर दर्द हमारा इलाज हो रहा है इस समय डॉक्टर काफिया के नाम से है सर। तो यहाँ पे जो हमारा इलाज हो रहा है तकरोही में, तो सर हमको बहुत अच्छा है, और यहाँ पे इतना फायदा हो गया है सर कि हम तुम समझ लीजिएगा कि हमारे जो मतलब ऐसा लगता था कि जैसे चक्कर आता था, जैसे गिर जाएंगे, काम नहीं कर पाते थे, शरीर में मतलब बुखार आता था। और सर कमर दर्द, मतलब यही सब सारी जो है मतलब दिक्कतें हमको आ गई थी। तो जब से हमारी यहाँ दवा चली है सर, तो हमको इतना फायदा हुआ है कि अब तो जाते हैं तो सर काम वाम भी करते हैं थोड़ा बहुत, और बाकी इतना फायदा हुआ है कि हमको मतलब तबीयत हमारी एकदम हरी भरी है सर। हमको बहुत अच्छा लगा था, बहुत अच्छा है हमारे लिए जितना मतलब कहा जाए उतना मतलब प्रधान योजना की तरफ से नहीं, मतलब उतना ही कम है। मतलब हमको इतना बढ़िया लगा, इतना अच्छा लगा कि सर हम अगर आज ये चीज हमारे पास नहीं होता स्मार्ट कार्ड, तो सर हम इलाज ही न करा पाते, और न तो हमारी दवा भी हो पाती, और न तो अब तक हम मतलब इतनी दिक्कतें आ जाती कि पूछिए नहीं सर। लेकिन स्मार्ट कार्ड जो हमारा यूज हुआ, हमारा जो लगा, उसके जरिए पैसा इकट्ठा या कैसे क्या हुआ, वो जो है मतलब हमको इतना फायदा हुआ कि सर अगर वो चीज नहीं होती तो सर हम बच नहीं पाते सर। जी सर।
Thank you. So, I often say if we will hear one call a day, we would be so dedicated to this scheme, because these beneficiaries are so grateful for the treatment that they receive free of cost, because a lot of them say we could not enter the private hospitals but for this scheme. And this is a chemotherapy patient in UP, whose voice we heard, but we did not give the identity of the patient. Now, without much, taking more time, my job is to moderate the panel, and I would request the chair, Shri Abhishek Singh ji, to give his opening comments. And okay. Sorry, sir, you can. Oh.
Thank you, Ms. Jaswal, the chair of the session, respected sir, the co-panelists, and the presentation by Ms. Malti has really laid down the kind of context for this panel discussion. We have very distinguished speakers who have done a lot in this sector, who will be sharing their thoughts, but I would just like to mention a few key points. Like when we are talking of empowering the beneficiaries and monitoring of the scheme, when we empower, like rightly she mentioned that IEC plays a big role in empowering people. In fact, what I have experienced is that very often we would come across eligible people who would be in need for chemotherapy treatment or any kind of kidney related treatment, for which will cost a lot of money. People get bothered, poor people really get bothered when the cost of any treatment goes beyond 10,000 rupees, beyond 20,000 rupees, and then they struggle to find out how to go. So I remember in fact a few years back when Praveen was in NHA and I was in Nagaland, there was an old man who came that his wife was suffering from cancer, and he wanted some financial help. In the Northeast, very often people go to government officers and people who can have the resources to help and ask for financial help. So I just asked them, are you not a beneficiary under Ayushman Bharat scheme? They didn't know. But then I made a call to him, then somebody from the Guwahati office contacted, I shared the Aadhaar number, the details. They checked and we realized that she was a beneficiary. And then ultimately she could come to AIIMS Delhi and they could get treatment done. And there were many such stories. So the key problem is that how do we cross this badge? Like there is a toll-free number, there is a way to go to forward to, but how do we let people know that they might be beneficiaries of this wonderful scheme which can help people not lapse into poverty? Because many people we have experienced that when they face a health issue in their families, their savings go there and they face a lot of hardships. So for that, I would say that several measures, of course the ministry is doing a lot, but what we did, we tied up with NHA, and like for example, all the Ayushman Bharat health cards are also available in DigiLocker. And having that, what it does is that it becomes easily accessible. Just like the COVID vaccination certificates, when it was available in the DigiLocker, it was easy to retrieve. Just with your mobile number and OTP, you could get the certificate immediately. So getting access to your health card becomes very easy if it can be automatically be pushed into the DigiLocker of all citizens. Then the second thing which we have also been trying to help is that we came up for other government schemes. We came up a portal called My Scheme, myscheme.gov.in. What it does is that it tells you the benefits that one may be entitled for, because very often in government we design schemes for people and beneficiaries for whom the schemes are designed, and this applies across departments. Sometimes they don't know that there is a website on which they can go and apply online for something, or they can download an app and get something, and even if they knew, sometimes it's very difficult to download an app or navigate a website. So what My Scheme does is that My Scheme app or myscheme.gov.in, there you go and you say your demographic profiles. I am a farmer, I am from UP, my income is 10,000 rupees. You give the basic details, and the portal will tell you, okay, so many departments have so many schemes from you. The scheme for you, the scheme discovery becomes easy, and then you can on then and there apply for a scheme and track the delivery of that scheme. So similarly, if we can build up a system in which we can just key in our Aadhaar number or mobile number or basic demographic details and get to know what is there. And in My Scheme also we have taken it to the next level by using Bhashini APIs, wherein people can actually ask questions on a voice interface. that you go and ask, just like we talk to Alexas and Siris, on Umang several such services are there, and we can think of collaborating to developing it, that hey Ayushman Bharat, kya mujhe benefit mil sakta hai kya? Then the voice will ask their Aadhaar number or whatever number is there. And then if on voice this information is given, that will really empower the people to discover whether they are having the benefits or not. So again, the key thing is that we cross this bridge and then we explain to them how to get the benefit of the scheme, what are the entitlements, in what ways, if there is any payment required or not required, which are the hospitals in the in the geography near where the person is living, and that would really help in ensuring that people start getting benefits more than what they're already getting. As far as monitoring is concerned, in fact, she rightly presented the insights that can come from data analytics. In fact, once we analyze this data, we can not only do fraud prevention, but we can in fact even think of predicting what's going on. Like if there is a particular disease of any particular kind which is coming in some areas, then one can think of there might be other geographical factors or some other factors which are leading to that. So doing this analytics, working with the real engineers and building AI models can really help in having strategies and policies for disease prevention and ensuring that we are able to actually benefit the people in a better way. So I would not take much time since we have a stellar panel, and just share these thoughts as my thoughts before we go to the panel. So thank you, Manthan.
Yeah, I request Chair Shri Manoj.
As has been already pointed out, very important issues are being discussed as far as PMJ is concerned, and very useful presentation PPT has been made by the Ms. Malti, and then substantiated by our co-chair. Now the thing is that the beneficiary empowerment, as the word suggests, rather the phrase suggests, it is the most important thing. It is the most important thing in the whole scheme, that how exactly the beneficiary is empowered and he or she feels empowered. They should feel that they have been empowered amply, and also it has to cut the huge amount of cost for them, so that the out-of-pocket expenses are reduced to barely minimum. Because after the consumption expenditure in a poor and low-income family, if suppose somebody falls ill, then suddenly the huge burden comes on that family. So the beneficiary empowerment, as shown during the PPT, amply brings out this point, and I think during the panel discussion it will be further brought out before the audience and before those who are sitting along with us. Then strengthening monitoring mechanism, it is by far one of the most important point, because we cannot allow any scheme to work in vacuum and without checks and balances. It is one of the most important part as far as various government schemes are concerned. So already we have got sufficient data since the scheme was started in 2018 all across the country, and this data has to be constantly analyzed, and the use of artificial intelligence can make wonders as far as the monitoring mechanism is concerned. But along with the computerized monitoring, the monitoring also has to be done by various human methods, by human teams, and it has to be kept on strengthening. In very briefly, I will tell about Gujarat. In Gujarat, because the scheme is very popular, and the amount in Gujarat has also been raised from rupees 5 lakh to 10 lakh for the insurance, in which rupees 1 lakh is being given by our insurance company, and rest 9 lakh is covered by the.
I mean, the people are not able to hear. Okay. Can you increase the volume?
Hear?
Raise the volume.
Maybe I come closer to the mic.
Yeah.
So, because our scheme was going on since 2012 in the name of Mukhyamantri Amrutam and Mukhyamantri Amrutam Vatsalya, and it was providing the insurance, and it was covering up to a certain level of the income. Now at present, the income levels are rupees 6 lakh, up to rupees 6 lakh income. We cover all the families, and there are some specialized groups also, which includes the widows, the elder people who are above a certain age, and in fact it covers our 90 lakh families out of 1.25 crore families. So I think that's a huge number, and large amount of our funding, because at present our budget is something close to 2700 to 2800 crores in Gujarat, and 80% of this goes to various private hospitals. So the beneficiary is really empowered in this way also. They can choose to come to a government facility, and they can choose to go to a private facility. At present, maybe at a large number of interior places, at large number of even cities, I should say, they are also preferring the private facilities. And in a way, it helps the government facilities also, because they are also under constant pressure. They have to compete, because government is also spending a lot of time. So that also improves the government facilities in turn. So all in all, it is a beneficiary empowerment automatically also, and through various methodologies of the scheme. So with these opening remarks, now I'll request our moderator to take it further with the various panelists, and then we'll move ahead. Thank you.
Thank you, sir. I now turn to Dr. Praveen Gedam, who has been our additional CEO in PMJ. Sir, with your experience of very large programs earlier, I was reading your biodata also, like Nashik, Mela, 2 crore people, and other large projects in your previous role. Like many of the beneficiaries are not aware, as we mentioned, and right now we are not saturated the cards, so the card saturation is an indication that all the beneficiaries are not aware, even though card was not a mandate. So what would be your suggestions how to take it forward from here, from where we are? Like, how do we reach out to those beneficiaries? We have tried most of the things, like right from the ground, ASHA worker to, social media. So what other magic we could do?
Yeah. First, when it comes to beneficiary empowerment, you have to understand what are the steps that are required. First, that there is a new scheme, new policy which gives these kinds of benefit. I think that message has gone. Initial few years were spent in that. But then the most difficult aspect of beneficiary empowerment as far as PMJY is concerned is to tell the beneficiary that he is a beneficiary. Because the criteria for being a beneficiary are quite complicated, difficult to explain, and even more difficult for a person to understand that these are the occupational criteria, these are the deprivation criteria. A villager or even an educated person will find it extremely difficult, and the only way is to tell him, okay, you are a beneficiary, you are not a beneficiary, which is very different from almost every other scheme of the government, like subsidized food grains and similar other schemes. So this is a big challenge which we continue to witness in this particular scheme. And we have tried kind of several measures, like digital ways of reaching out through mobile apps, portals, call centers, etc. But I think physical efforts have been more successful. And I remember the spike that was seen in the uptake of the scheme in Jammu Kashmir. We could attribute it largely to distribution of cards. After which we decided, okay, let's distribute the card, even though it is not required, the card is not required to take the treatment. It gives that sense of empowerment that, okay, I now have a card, I am a beneficiary, my family members are a beneficiary, I can go to any hospital. So I think we almost have reached 45% or something when it comes to distribution of card. There was also a problem about database, which was later on solved, that somebody who is not identified in the scheme can be replaced by an alternative person at the state level. So I think what is required at this stage is a kind of carpet bombing, like going to every single village and telling each and every person that he or she is a beneficiary. So that approach is, I think, required on a massive scale. We have already tried letters and posters and booths. The next challenge that I see is to know where he can take the treatment. Like where is the list of empaneled hospitals? And then we have empaneled hospitals of central paramilitary forces. But then people don't know, they don't feel like, okay, this is a hospital dedicated to uniform service, and there is not it's not in the mindset that I can go and seek the treatment there. So that is another challenge because of the different schemes running parallelly. We also have that additional challenge of communication, that several states have two parallel schemes, PMJY and state scheme, with different criteria and at times different entitlements in terms of packages available, etc. So that's something I think that can be achieved by proper running these two schemes in sync with each other, proper convergence or dovetailing of these schemes with similar packages, similar annual ceiling per year coverage, etc., etc. I think a lot has been done. Honestly, we have almost, I think, 6 to 7 crore inpatient treatments, which is a fair number, and we should increase it by now, going more and more proactively through Ward Sabhas, Gram Sabhas and physical modes, in addition to continuing with the digital ways of IEC.
Very well said, sir. Thank you very much. I now turn to Mr. Rajat Vij, who in his biodata I read that you are also consulting for some of the development programs of the government. So are there programs which face similar issue, and how do they tackle about beneficiary awareness in those programs? Is my question to you, Rajat.
Sure. No, so absolutely. I think as part of a lot of other programs, while obviously, I mean, the scale, size and the reach of, this program is unparalleled. And I think, I mean, this is one of the programs which perhaps would be the backbone of the health sort of, environment of the country. But if you, to draw a contrast to a skilling scheme, right, which has sort of, again, a fairly wide reach, and the challenge of not only awareness, but also, some of the specific aspects of a skilling program across the country, the process that has to be followed, the documentation that goes along with it. Schemes on the livelihood side, like, the MSME side, we have seen the KVIC schemes, where, the awareness aspect, as well as, the beneficiaries' eligibility for loans from the banks. So we see, a fairly good contrast among other schemes as well, where, awareness, communication, education and learning is an integral part of making the sort of, entire scheme successful. But, I see technology is going to play a large part in sort of, making this very, very effective. One of the aspects that needs to be considered, to my mind, is the type of beneficiaries we are dealing with. The people who are sort of, going to get benefit out of that, their sort of, environment, their sort of, compatibility with the technology side, and understanding. Like, I think I was reading somewhere, 86% of the calls on the inbound call centers were related to the card, Ayushman card related, or perhaps the eligibility related. So is there sort of, some bit of innovation that can be done through chatbots or IVR system? That may sort of, help one degree of sort of, communication there. The other aspect is the vernacular languages, right? So when we look at communication, I think that can sort of, play a good role in terms of sort of, the reach. One of the things I think, which I think my other panelists touched upon, was the convergence with the state schemes. I think that's a very, very important aspect, because, when there are multiple schemes going on, both from the awareness perspective as well as convergence at some point in time between those schemes is extremely important. Again, from an end beneficiary usage side. The eligibility requirement, I think, as this sort of, as a lot of measures are taken in terms of, going back and redesigning some of the aspects, maybe eligibility requirement is something that can also be looked at. So these are some of, the key aspects that I've seen in my experience.
Thank you, Rajat. I now turn to Dr. Manashvi. Kumar. Sir, I was reading about you and I was impressed with the book, Eradicating Energy Poverty, and a lot of research papers that are mentioned. So I would say that from the perspective, it is said that, that whatever gets measured gets done. Right, and a program of this size, it is huge, and we have to monitor, and we have to be agile also in making the course corrections as we are monitoring. So, what would be your suggestions to the policymaker side or the state health agencies? How do they use the information that's coming from the portals or from the dashboards that we have created? And how do we, what do we do to have those course corrections inbuilt into that mechanism?
Is it on, ma'am?
Yes.
Respected chair, co-chair, the moderator, my co-panelists, esteemed colleagues. It's a difficult sector. It's a sector laced with information asymmetry. I would begin with highlighting three fundamental precepts as a researcher. The first is social appraisal of technology. The second is social cost of technology. The third being social construction of target population. Where is my beneficiary, the larger clientele, placed? No two villages in this country are similarly placed. And when it comes to public health, with my limited experience, the concept is vector and not scalar. Handling a program of such a dimension and finding out ways and means for course correction is an arduous and a Herculean task. So I would always go back to the basics, trying to be conventional. This scheme is focused for rural India and also for population in urban settings. So when I talk of IEC, information, education, and communication, we need to look at things differently in both these settings, because we are trying to make a dent in the life of a common man or a woman for gender neutrality, who's largely engaged in an unorganized sector to earn his daily bread or living. Access to portals, access to data sets, access to dashboards, access to call centers, making an IVRS call, getting an automated response, are based on certain presumptions and presuppositions in terms of I am in an area where there's a profound outreach of connectivity, and communication. The basic purpose of this scheme is to make an individual Ayushman, meaning thereby the value what the scheme brings to you in terms of your health, happiness, and productive life. It's not about longevity per se. And there are so many dimensions and dimensionalities attached to it. We can go on breaking them. So when I come to the fact of granular understanding of IEC, it should begin from the panchayats. In this scheme, a lot of responsibilities are on the burden of the district, the tehsil, the block, and the village. The fundamental unit of either revenue administration or the fundamental unit of being recognized as a fundamental constitutional entity, the principal, the Gram Panchayat. We have dedicated months and days for our Gram Sabhas. So as I was exposed to various schemes in the Ministry of Rural Development, we used to ensure that when I talk of a policy intervention, or a programmatic dose, it has to be bottom up. I have to communicate in a fashion, in a mannerism which is in complete sync to the immediate output that I do expect and a nearistic, futuristic outcome. So I believe we have done well, but there's a long way to go when we have to take stakeholders on board. As of now, I would rest my case here. Thank you.
So, yes, now it is working. Yes, thank you. Arunchalam, now my turn. Now my task to turn to you with your rich experience as an actuary. My question is not on the actuarial side as yet. That will be my second question to you. Right now, what are the learnings from the insurance side you would like that could be adopted here? You know, policyholder awareness and policyholder protection of interest is a big regulatory area where all the insurance companies work very, closely with the regulator. So what would be your suggestion on this side? How could these beneficiaries with whose interests are protected, but they're not even aware of those? What would be your, suggestions on that side?
Good morning, all of you. Thank you, ma'am. Thank you for inviting me on behalf of Institute of Actuaries of India. I thank NHAI and the entire panel. I congratulate NHAI for the 5th anniversary. I feel that 5 is a very important number to achieve, and that brings the stability in any matter. And I feel that we have reached 5, and with the scale and with the concept of PMJAY, now the thing is it has to scale up further. With that, I'll probably come to some of the topics that's been already mentioned. For the sake of time, I'll not repeat. But if I have to look at from the insurance perspective in terms of the IEC concept that we have been discussing, the insurance traditionally is distributed. It's not it's a push product, and mostly it's distributed through agents or through banks. So there are touch points for the people, where the people come, they'll go there, and then it's sold over through that particular point. Apart from that, no, there are many insurance companies which are spread across the country. They have their offices. There is a physical presence as well. So in a way, it's quite, I would say the spread of the information is slightly different compared to what do we have maybe here. But I feel that with what I have seen in the presentation and also what I hear from various geographies is that it's gone pretty well. Of course, there is a lot to catch up. Some of the areas, as what's been mentioned by the panelists, in terms of reaching out to the villages and rural masses and making it a mass movement, people movement rather, like making celebrations out of this. For example, insurance, they have an insurance day, they have insurance week. If we can have, we do, of course, have a feedback mechanism. There is a lot of things that goes out, but if we can have at a village level or at a locational level some kind of an activity, it could probably be clubbed with some festivals or where people can group. So there's a lot of touch points. If I may also divide the entire population, there are different age groups. You have school students, you have younger guys who have yet to get jobs, then you have middle income. So if we can profile it and then reach out particularly to the younger and middle population over a period of time, it will definitely it will be of great help. I don't want to get into the tech part. I'm sure you will be doing it in a much bigger way. So these are the first very high level thoughts that I have. Coming to the second question, I lost your second question. You asked me something about the actuarial perspective. Right?
I'll come to that on the sustainability part. Yes.
Sure.
Okay. Thank you. I appreciate what I would like to share with you and with everyone. I think most of the people here are from the states. Ayushman Pakhwada is celebrated to bring more awareness. That is done, and I think the festival part is a good takeaway. Like if you can, I don't know, because since I don't work with the states, maybe they're already doing it, celebrating, building the celebrations around Ayushman, Bharat card. But that's a good suggestion. Now we will have since I said we will try to manage within time. So my second round of questions, I would request the panelists to be a little brief so that we can have some time for the audience as well for the questions. My second question is to you, Rajat, that what would be healthcare programs are always going to have integrity issues, right? That is going to be there. That is a given. How do we, we may not be able to stop it, but how do we, minimize it? What kind of, it's like a moving target. How do we outwit the fraudster? So what kind of a role do you suggest that latest technologies, I already mentioned in my presentation, we do have fraud analytics, deploying the AI/ML techniques and other technologies. What are the other, frontiers in forensics that we, NHA could look at?
Right. No, I think absolutely there is lots which is already sort of, put out as a part of the program. The prevention, detection and deterrence mechanism is well defined. There is, the triage that already exists. Data analytics actually I think is also very, very integral, and it was mentioned before as well by the panelists that a lot of data can not only sort of pinpoint frauds, but more importantly, from a prevention perspective or a predictive model perspective. But I think what is going to happen, there's two parts to it. One part clearly is technology, but which will be an enabler. But the other part is the on-ground intelligence, level zero or ground zero sort of work that can be done in this regard. So for the fraud program or an anti-fraud program has to be very comprehensively sort of looked at. If you see, there is what we call it in the insurance sector is a trio, right, where a collusion is happening between the TPA, the beneficiary and the hospital. In this sort of scenario, it is very difficult for sort of, any of the anti-fraud techniques or controls to discover or find out these frauds. Having said that, if you, add some of the business intelligence type of fraud procedures, anti-fraud procedures, that would help. Mystery audits, surprise audits, is a technique that is being used as well to sort of, again, bring back and pinpoint at a thematic level that where are the sort of, pockets where it is happening. By the use of data and technology, one can pinpoint on certain areas, regions, certain sort of, vendors, certain hospitals, have a risk grading sort of, approach as well, which will sort of, tell us in terms of a risk rating that where do sort of, some of the bad apple lies. Because at the end of the day, the focus of anti-fraud controls should be to eventually bring back the recommendations and strengthen the scheme from a design perspective. Some of the other techniques that we have seen is on the e-discovery side, on the forensic piece, wherein a lot of information these days is stored into computers, into phones, into hard drives. A lot of electronic evidence and electronic sort of trail is available. So that's something which we are seeing helps. Some of the more newer forensic techniques that we are seeing being used, and especially on the on the Western world and some of the other countries, are tools like voice assist. And this voice assist enablement is actually being implemented on the beneficiary end itself. Because, from a grounds up basis, some of those techniques may just sort of, again, put another degree of deterrence, from that perspective. Blockchain and process bindings are also some of the other techniques, but I still feel that, look, technology will be a very key enabler in this, wherein the powerhouse will be data analytics, but the integration with the ground level realities here, by the way of mystery audits, by the way of accumulating information through business intelligence and otherwise, is going to make, a fairly comprehensive, anti-fraud framework here.
Thank you, Rajat. That's a very important point that you make, and I come to Dr. Praveen Gedam. Sir, like technology can take us thus far, and we all know the importance of human supplemented by human effort, especially for fraud control at the ground level. But how do we build the capacity for the same? We have such a huge issue in building capacities of of the on-ground teams. We have tried to have workshops, we try to have training sessions, but still it remains a big challenge.
Yeah, I think we need to tackle this at three different levels: center, state, and district. And before I go to explain these three, what is to be done, we have to understand that this is not a science. Medical science is not like maths or physics, where 1 + 1 is always 2. And there are lots of gray area. So we have to understand the differences between the hard fraud, where, for example, somebody is not a beneficiary and still provided a treatment, or there is no treatment and the claim is submitted. Then there is abuse of process, medical procedures like hysterectomy or C-section may not be required, but it is still done. And then there is a bigger area where we really can't make judgments, because every physician or a surgeon may have his own individual way of treating the patient. And therefore, we have to further improvise tools that we have developed at the national level. Like we have already have a tools which can detect a same beneficiary getting treatment in a narrow time limit at different places, or a same doctor treating. So these kind of tools we have to keep developing further and further at the NHA level, Then also for abuse process, I mentioned about hysterectomy. So we said that, okay, we have this standard guideline that for hysterectomy, you show me the proof of 6 months of failed medical treatment and then judgment of 2 gynecologists before you decide to remove the uterus. And then there are some challenges also in the field. I'm not going to into that. So these kind of policies, one policy is there that C-section will be paid the same amount as in case of normal delivery, or some states have decided to reserve the treatments at the government hospital. So this is something which is to be done at the national level. But I think the challenge lies more at the institutional strength at the level of states. And even worse is the condition of the district, where 1 or 2 persons, they are trying to do everything together. If you see the schemes of similar magnitude, we see really strengthened a strong district implementation unit, as in case of sanitation campaign or similar other schemes of similar flagship schemes. I think that is something which needs a very strong push from the state governments. And even at the SHA level, there are some more capacities are required to be built. And one more thing that I think is missing, we have enough number of policies, but that deterrence pillar, in the slide you show 3 pillars. So deterrence pillar needs to be even more stronger, because if somebody is an habitual offender or there is a malafide intention and not a bona fide mistake, then I think we need to have cases, both civil and criminal, throughout India, in all the states, in all the regions, so that message very clearly goes that there is a zero tolerance towards fraud and abuse. So it's a very, I think we have capacities enough. We need to improve further at NHA level, but more needs to be done at the ground level.
Thank you, sir. I think that message is coming across from all the panelists. That's a you know. I turn to you, Arunchalam, regarding the question on the sustainability of the scheme. You see, monitoring and is very important for creating sustainability of the scheme. And then, how do we weed out the leakages, to get the maximum value for each rupee the government spends? What would be your, suggestions on that side?
Yeah. I was pretty happy to look at the title of this session, beneficiary empowerment and strengthening the monitoring mechanism, particularly from the pricing perspective. Unless we have a very strong monitoring mechanism, the price wouldn't be sustainable or viable over a long period of time. I would say viable, maybe it would be more than what's actual. If I look at the cost, see there are 3 aspects to it. One is the actual cost of the benefit itself. The second one is your, I would say over year on year there would be an inflation. So if you look at only 1 year, it's only the actual cost. But it will keep on increasing over a year. So we can look at what happened in the last year vis-a-vis current year. The third part is the leakage part, right? I mean, generally over the world, there would be, as what Praveen ji mentioned, it's very borderline because it's a medical area. Some of the procedures, would be different between different medical practitioners, and hence we'll have to accept what's come over there. And a leakage of around 5 to 10% is an acceptable level over the world, right? I mean, you may not know whether it's actually leakage or not. No, people may classify it differently. But if it is more than, say, 20%, 25%, then we do really have a serious problem on that. Now, how do we address this leakage? Technology enablement is the first best option, and I'm sure you have already started with the exchange part. And if we have a very robust system that cuts across the center to state to the district, where we have a complete visibility in terms of the member, in terms of the claim, that will definitely help out in terms of identifying some of the patterns, identifying some of the impersonations that would be happening. What happens in an insurance industry in terms of identifying fraud, especially from the health aspect, is that they do a lot of underwriting per se, right? They do both at the time of enrollment and at the time of claim, and given the PMJY concept, and I think we should look at more at the time of claims. And how do we do that now? It's a scheme, it's a benefit scheme, and how do we ensure that the claims that come to us are correct, right? And that's where just not a system, but also a network of people and mechanisms have to be built around. But having said that, there are other techniques in terms of looking at not just the statistical techniques in terms of clustering or pattern finding. There are some actuarial techniques as well in terms of looking at what could be a likely particular claim incidence in a particular geographical area, right? So generally the insurance is based, the insurance experience is based on the past trends, right? We look at the past data to project what would happen in the future. And because we do it for a large set of people, for the population as a whole, it would hold good. Of course, there will be variation if there is a COVID year or something like that, but generally it holds good. And India having such a large, diverse country, we have pockets, we have different districts, we have different states. The experience in states could be different.
Sure.
The experience in age groups could be different. So we can look at the details of that. So then all of that can be plugged back into the price. Then we would get into a sustainable price.
Thank you.
That's a very
That's a
brief,
very
I don't know, and there's quite a lot, but I'm sorry to have expanded time, but
I
that's
get
a
it.
quick thought.
Maybe I get it because of my background in insurance, but I think it's easily explained. I'm sure others also got it. We have, I will turn to Dr. Manashvi Kumar, sir, and like if we were to launch PMJ 2.0 with expanded base, expanded base and benefits and, new IT, what would be yours, 2 or 3 things that you would say that take these on priority?
So, ma'am, thank you for asking that. So then we need to understand the difference between review, monitoring, and evaluation. First thing. The second thing would be any scheme, if it is to be taken to a next level, battling whatever we have been seeing what has happened with the scheme, is the element of trust. The states are more than equal partners, right? The states have to be given more leeway to improvise. For us, it does not matter where the citizen is located or shifted or co-located. So, for purposes of review, you need to have different modalities. For the purposes of monitoring, you need to have different functionalities. And for the purposes of evaluation, you can have your own tools. The fundamental premise is of trust. How that trust, the element of trust, what are those networks of civic engagements that can be inculcated? And then the process has to be repetitive. It has to recur. So sitting here, rolling out a scheme, the scheme is seen in action in the state, in the district, in the village, and the block. I would again go back to the same iterative, grounded theory, mixed methods approach for understanding a scheme and making it work. Thank you.
Thank you. I think that's very useful. We will honor the audience as well and have a couple of questions. As much as you want to be away from lunch, feel free to ask questions, okay? Right? So that's a choice is yours.
Yeah,
let us have some questions, and if we can have some mics. I do not know who, raise the hand first, please.
Madam, I am a surgeon, mainly an orthopedic surgeon, also coming as a dean from AIIMS Raipur. The problem is once
Sir, please address your question to whom?
Praveen Gedam, sir.
Okay.
So there are three things to it. First of all, once the patient breaks his bone, if we want to operate, we have to wait for the permission to come. And the patient is told, दिल्ली से परमिशन आएगी तब आपका नाम इंक्लूड होगा. Sometimes the surgery gets delayed.
दिल्ली बहुत दूर हो गई है.
But that is point number one. Okay. Point number two is the implant that is coming at times may not be the exact implant which is needed. And the third thing is that there are two types of Ayushman beneficiaries, those who are poor and the whole cost comes to them. But there are some people who are above the 50,000 limit. So they get 50,000 from the government and they take better implants. So there is a discrimination. So people feel कि मुझे अच्छा implant क्यों नहीं लगाया. So these three things I wanted to see what are the guidelines.
Yeah.
Thank you.
So the first question was what we call as pre-authorization of treatment. Before you do any treatment, you take approval from, it comes from state capital most of the cases, not Delhi. And there is a system in the IT system that if it is not decided within 6 hours, it is auto pre-approved. And sometimes you may not be even willing to wait for 6 hours, right? So I think in that case, because you can't make it 1 hour, 2 hour, because you have to give enough time to the person who is dealing with it. So I think in many cases, the Arogya Mitra of the or Ayushman Mitra of the hospital, he can pick up a phone and call the state health authority office and get it expedited. I think that is the first part of your thing. Second was implant. In the first version of health benefit package rates, we had a specific, so I don't remember exact rates, but let us for the discussion, TKR, total knee replacement is for 80,000 or 1 lakh, whatever. Now in second version, what we did, we understood that, okay, this 80,000 or 1 lakh rupees, it has two components broadly. One is the surgical component, the skill part of the hospital service, and the second one is actual cost of the implant. Let us say it is 60,000 and 40,000. So we made it into X plus Y type of package rate. So X rate is fixed and Y is variable based on the type of implant, so that you can get the different types of rates for same procedure depending on the different. It can apply to stent or whatever. And then this, I don't know this 50,000 where it comes from, maybe some state.
So it may be a state scheme.
State specific issue.
They get a benefit up to 5 lakhs. The people who are not poor but they are still having the card.
Got that. So I think this is
So
a
it's a
state specific
state-specific
scheme
I
probably.
agree with that.
And that is
must
what
be
I
happening.
said in my first comment, that this creates a confusion and
I'll
discrimination.
add to what Praveen was saying.
Convergence is something which is required to have two schemes which are similar in terms of benefits provided, the coverage provided, the entitlement part of it, and also hospital management part of it. And that will come if the states decide to converge the schemes, which has recently happened in state of Maharashtra after a lot of push. But I think few other states are still remaining.
Already, since you are from
Sir, before we come to you, a woman has raised hand. And yesterday we said women should have voice.
Malti, a moment, I'll just add to what Praveen has said.
Yeah, sure, sir.
The pre-auth, I think we have to be a bit more human, and the treatment is the first thing.
Absolutely.
And that is being adopted by many hospitals all across the country, including Gujarat. So that is the first approach. Technically you may say, okay, authorization has not come, but some fund in some way or the other is kept by various hospitals to cover those where this may fail, this pre-authorization and further approval is fails. And convergence in Gujarat has already taken place. The local schemes have been merged. In fact, there is no different scheme. There is only one scheme, PMJ Ma. Ma is Mukhyamantri Amrutam. So that has been merged. So there is no issue of segregation of schemes.
I think absolutely, sir. The treatment in emergency, any patient's life is more precious, scheme or no scheme. I think that's a fundamental, law for all hospitals. There is a woman who has raised her hand, and yesterday we had a woman who complained they are not being invoiced. So you will give her the chance, and then we'll come to you, sir. Yeah, please. We can hear you.
Not being there fully. Thank you. With OPD coverage still not being there fully, what can be done to? And this question, let me point out, is to Dr. Praveen and to Dr. Manashvi. Anybody else is, of course, can definitely add on. So, what is the role of uplifting and bringing in regulations towards healthcare providers? So, actually upskilling them, where they know what is, their kind of a job and how can they do it better. The second question I have is, what do you think is the role of there being, various like private players in actually helping implement PMJAY, whether it's to, whether it's towards fraud detection, deterrence, prevention. So do you see an interface between, like private companies coming in to support the government, or even IEC? So, if you could allude to these two topics, it would be, quite helpful. Thank you.
Sir, would you like to answer?
Thank you, ma'am, for asking that. So now I'm swinging between two worlds that I normally see on a daily basis. One is CGHS, and the other is PMJ. The universe is different, the clientele is different, the purpose is different. So PMJ is exclusively for secondary and tertiary. While when I see CGHS, we are first providing OPDs, followed by referrals, and then we have our systems in place, which are normally not liked, rather, for want of a better word, cursed, because my mailbox is normally full of complaints and grievances. Now, we have to understand one thing. Both these schemes are aimed at quality healthcare. What do I mean by quality healthcare? When quality healthcare is being looked at from a financial perspective, the single unit that I'm looking at is out-of-pocket expenditure. Now, this is not only for my client who has come to avail a facility. It could be a surgery, implant, immediate treatment, hospitalization, authorization, care, stay, everything. But also the burden on the service provider, which could be a healthcare facility, whether in public or the private. And let me first also say that I am not looking at duality of healthcare. It's the basic minimum quality service which has to be assured. Sir made a mention of health packages. Now, believe you me, for every single procedure, the inputs in designing of that particular package would vary. You give that job to a team of professionals who are experts in doing medical audit, you would come with a different costing for every single procedure. And many a times, these samples are also not sufficient. So I do not know whether I have hit the nail on the head or I am somewhere near to answering your question. The issue remains that healthcare is to be given. We also need to be fully cognizant of the fact that what is the larger aim? Are we moving towards curative healthcare, or the focus as on date should be towards preventive healthcare if we are to reap the demographic dividend? This is a question that I keep on asking myself on a daily basis. Thank you.
Dr. Praveen, you wish to add a question? Yes.
Very short and very brief.
Yes, very short.
The first part was the OPD coverage. I think that's why it is not covered, and I think this is a challenge worldwide to provide, to involve private sector and insurance component for OPD, largely because of there are several reasons, but the prominent one is that cost of one OPD consultation is say 200 rupees, and the claim processing takes say 70-80 rupees, so it's not very financially makes sense to have that kind of system. Secondly, it's very difficult to prevent fraud and abuse. Practically, I'll say almost impossible. How do you check whether the person actually had a common cold or a viral fever after 15 days of and the numbers in India, OPD numbers are 450 crores every year, so it's a big challenge, and that's why OPD component is not missed in Ayushman Bharat. I'll tell you, it's covered by an alternative parallel scheme called Health and Wellness Centers, which is totally run by the so it's not missed out, just that it is run by ministry in a separate parallel way, and you have to have better continuum of care and linkages between these two streams. That's first thing. Upskilling of healthcare professional, I think the best policy system or software is the one which requires least amount of information to be given to professionals for getting it started and running. What I mean to say, that scheme should be simple enough to understand with few 5-6 bullet points, 5 lakh coverage per year, family size is unlimited, etc., etc. If that message is passed on to the doctor or a nurse or any other person, I think he should or she should focus mostly on his or her professional strengths without bothering for these administrative things. He should be just able to know that, okay, there exists a scheme like this, and I should be able to tell a patient, okay, please go and check if you are a beneficiary or not. Rest, it should not be much relevant.
Yeah.
I think I'll stop there.
Thank you, sir. Thank you. We should give the front bench a chance.
Okay,
Yes.
thank you, madam. My question is to Dr. Praveen.
Sir, mic is not working.
He is sitting here.
Yes.
Yeah. Is it no? I think I'm audible here. So my question is actually I often see there are many this state government schemes having the almost similar title to that of the central schemes, and there is a lot of confusion actually. Especially, I'm from AIIMS Patna, and often I get actually a lot of complaints from the patients. Being the director of the AIIMS Patna, they claim something, and then you find that actually they are claiming in the state scheme. Of course, at the institute level also we integrate. But my request actually, something should be done actually to integrate the state scheme and health scheme, which will be, so much helping to the public, especially when the public is not that much educated. Second question actually to Dr. Manashvi, my question is, what Madam you presented actually, I am so thankful to you, gave the details of the fraud detection. At AIIMS Patna, often we see, lot of these fake claims, and then to check that the registration process becomes so big actually. One registration takes 30 to 45 minutes, and that is why also the registration gets slow.
Sir, please close your question quickly.
So my request actually, how can we expedite actually the detection of fraud?
One question, one person.
Yes, yeah.
One panelist, one person.
Sir, you would.
Okay. I think you just reiterated what view I said, that for 4 years the National Health Authority has been pushing states to converge the scheme and make it a one scheme, because it's creating a lot of confusion among educated and learned people and those who are in government like you too. So imagine the situation of a villager who is not even aware of government, how governments work. But there are like broadly 2 reasons. One is that there are a lot of legacy schemes like Chiranjeevi or the earlier Bhamasha in Rajasthan, then Arogya of South India, then in my state Mahatma Jyotiba Phule. So many, these are legacy schemes which find difficult to get converged. And the second issue is probably of political nature, whether they want to converge or not. Health is a state subject, so final call will remain with the state government. It is in the interest of the scheme, beneficiaries, resources, everything to get these 2 schemes convert into a single scheme, no doubt about that. I think other panelists,
Madam,
maybe question you can direct to other panelists also.
Madam, just
Registration. We believe that we have sessions on scan and share, sir.
Yeah,
Right?
absolutely.
So we hereby that, again, going back to my initial observations, we need to have a mobile, we need to have an application, and that application should be able to recognize, scan the code. Then there is an authorization if you have a kiosk for PMJY at AIMS, because yes, I'm sure you have. And I would also request that since we have already an MOU with you for CGHS also, I know, sir, you have that also. So, meaning thereby that we have for Ayushman, Ayushman Mitra. What I would request our colleagues from the private sector and also from AIMS is to have a dedicated cadre in your hospital itself, and for the sake of a better phrase, allied health service, where even your nursing officers can be one of the myths. Like, okay, this is this scheme, this is a clientele, this is how you can expedite the registration process as we do for PMAY, so through PMAM. For want of time, this was my limited response. Thank you, sir.
Madam, there is a Madam, as there was a gender bias, we see a bias like, private sector has never been allowed to ask questions. So with due permission and respect, can I ask one question, ma'am? First of all, I am from Gujarat and I would really appreciate Manoj Aggarwal, sir. You are the only one panelist in last day and a half who saw empowerment in a beneficiary when he was entitled to seek treatment in private sector. I feel there is a marginalization of private sector, sir. We have been a very important player in executing this scheme, but all these sessions I hardly find anything for private sectors, and what all panelists keep talking about is how to improve the government things and how to empower the public infrastructure so that we can divert fund from private to public. Let me remind you, when the COVID pandemic, the private players came to help government and cater to the healthcare services. So simple question, sir, why is there marginalization of private sector?
Marginalization of private sector.
Sir, we actually are here to seek your support in upgrading our own, ability to cater to the services.
Your point is very well taken, but first let me, since you have asked in the context of Gujarat, let me clarify in the context of Gujarat, as I mentioned in my opening remarks, already 80% of the PMJ is going in the private sector.
That's what's here. That's
so
what.
I think that gives you some solace.
But that representation is not.
Sector is not being given the due. You may say they are not taking on board. But I think they are being taken on board, and it, as I mentioned in the opening remarks again, it also encourages the public sector to definitely come at par.
Absolutely. Yeah.
And definitely they have to keep on improving their standards also, which is also very important. So I am sure it is being recognized. I am not sure about other sessions. You are saying that we are getting some different type of treatment, but that may not be true, and that is only your perception.
We need more of you in Gujarat.
Sir, if I can say that data speaks more than the words. So 80% if it is in Gujarat, private sector is definitely not marginalized. Anyone would not call it marginalized.
What comment
Yes.
I would like to make based on all the questions that have been asked and what the panelists have been speaking. So what I was wanting to think, and I was thinking through from my technology hat, is that one project that is being implemented by Ministry of Health and Ministry of IT, e-Sanjeevani OPD services. We have like almost 400,000 daily consultations on that platform. So if that can be popularized more, and if private sector doctors can also join in, right now it's mainly government sector doctors, then we can really increase the access to healthcare for basic OPD services. And then in case Ayushman Bharat ever decides to add OPD with the fraud prevention and all issues that Praveen highlighted, when there is a video consultation, then the record of it is also preserved. So if we have to reimburse the cost to a doctor who is providing that service, that can also be factored in. And the second would be that use of artificial intelligence in trying to do prescriptive medicines. In fact, there are a lot of AI bots, a lot of startups have started providing these services, which act as a tool for a doctor and hospital to assist, plus also reduce the time taken for a medical consultation. So some technology interventions can also help address some of these issues.
Thank you, sir. In fact, you summed up to a large extent, some point that we had missed. Now I request the chair to, sum up and give his suggestions and advice. Thank you.
This Arogya Manthan, as we all know, is going on since yesterday, and I think the completion of 5 years of ABPMJ and 2 years of ABDB, which we are sort of celebrating with the Arogya Manthan, is a very important step. And when I saw various technical sessions, I think more or less everything which is concerning PMJ has been covered. So I don't know how many sessions one can attend because parallel sessions are going on. But today's session is also very, very important and highly relevant. All the panelists who have spoken, they gave a lot of insights regarding the beneficiary empowerment, which is the most important thing in the whole scheme. As the beneficiary who could be lower income group or a poor person, or in a few states if the income group has been mentioned. So the beneficiary should know what his rights are and maybe what his duties are also. Duties in the sense that how to, because it is interlinked with the prevention of fraud also, as mentioned by some of the panelists. So beneficiary empowerment right from the IEC, having various camps, having various campaigns in the form of Ayushman Bhav program, which will continue for a long time, taking it to the Gram Sabhas, taking it to various other panchayats. So, and in the urban area also, at the ward level and the higher level of the urban local governance. So beneficiary empowerment is a continuous process. So that has to continue, and similarly the monitoring mechanism, we have to try and reduce the fraud as much as possible. We have to use the latest technology as mentioned by nearly all the panelists who tackle this subject, and at the same time the human angle also has to be continuously be there, and some of the issues which were tackled were that the insurance gives a lot of insights, because this is in a way an insurance scheme, that how the people are behaving in a particular pocket, in the particular geographical area. So all those things, they enrich the monitoring mechanism under PMJ, and I think the PMJ is now ready to go to the next higher level, where we have to strengthen it, where we have to ensure that more and more packages are available to the people at reasonable cost to the government. So that is already a thing in the thing which is happening, and it is a continuous process. I thank all the panelists and especially the moderator.
Thank you, sir. It was my privilege to moderate this, big round of applause for the panel. And big round of applause for the wonderful audience as well. Thank you very much. It was really my privilege to be here and moderate this session. Thank you. Over to you.
Thank you, everybody. Thank you to the distinguished panel for such an interesting and interactive discussion. We'll conclude with a small memento distribution. I would like to request our moderator, Malti ma'am, to hand out the memento to our chairs for today's session, starting with Mr. Manoj Aggarwal ji. To Mr. Abhishek Singh. I would also request her to hand out the mementos to our panelists, starting with Dr. Praveen Gedam. Dr. Manashvi Kumar Singh. Mr. Rajat Vig. And Mr. R. Arunchalam. Thank you, everyone. We break for lunch.